This video continues Chapter 9 on airway management, and specifically we want to look at the adjuncts that we might use to maintain a patient's airway. That will include just a quick review of the skills for OPAs and NPAs. Let's begin. One of the first tools that we can use to maintain a patient's airway is placing them in the recovery position. That's also called the left lateral recumbent position. Take it apart, they're on the left side, left lateral, recumbent, lying down. So that works for an unresponsive patient and someone who may have an altered level of responsiveness. And that technique will let you take care of the patient's other chief complaints. What we want to do in this case is go ahead and extend the patient's arm over their head. That will support the head and keep it up off of the ground. Roll the patient onto their left side so that their head is resting on that arm, and then tilt it at a downward angle. You can't turn gravity off, so any vomit or secretions are going to drain from the mouth and keep the airway open. Flex their knee at a right angle, and that kind of becomes a kickstand to keep them in that position. And then the right arm is going to be in front of the patient in such a way that you can still keep an eye on that airway. Now, additionally, we have a couple of options to keep the airway open. These are adjuncts. The nasopharyngeal airway, think about that anatomically. It's going to go through that space behind the nose, and the oropharyngeal airway going into that space or that cavity behind the patient's mouth. Now, the choice just depends on their level of responsiveness, and we always want to maintain the airway in an unresponsive patient with one of these adjuncts. Let's take a look at the NPA, sometimes called a nasal trumpet, very descriptive term. You can see its shape. They're made of a soft plastic that will allow them to be placed inside the nose, and basically it becomes a conduit from one of the patient's nostrils all the way through the nasopharynx. When it's properly sized, it's going to be well tolerated, even in a responsive patient, because it doesn't go through the back of the mouth and stimulate the gag reflex. They come in a variety of sizes, and it has to be properly sized. Remember not to use this with head or facial injuries because the complications from pressure on that injury could be very severe. To insert an NPA, we've got this acronym. We want to size the device. We want to lubricate the adjunct. They'll come packed actually with a surgical lubricant that helps it go in. We want to insert the device and then check for its patency, its effectiveness, and if the patient's level of responsiveness improves, we can remove the NPA, considering that the patient can breathe on their own. The oropharyngeal airway is not a soft device, it's a rigid plastic device. We have two varieties we see here. One has an airway channel down the middle, kind of like a tube. The other one has grooves alongside a rigid center, and air just passes down those grooves. Now, when the OPA is in place, it maintains patency in the airway by not allowing the tongue to fall backward. It's contraindicated for a patient who might be somewhat responsive, because if they have an intact gag reflex, you can't insert this. Now, this is a great airway to use if you need to help the patient breathe with a BVM. OPAs come in several sizes, and they need to be sized as well. We're going to size them, insert, and then check for their effectiveness. Now, just real quickly, this is a specific skill, but the sizing is pretty straightforward. For the NPA, size from the tip of the nose to the patient's earlobe. The NPA goes in the nose, size it from the tip of the nose. The OPA is sized from the corner of the mouth to the patient's earlobe. The OPA goes in the mouth, size it from the corner of the mouth. One more time, be very careful with an OPA. If they have any responsiveness at all, you can stimulate the gag reflex and actually make airway management worse if the patient vomits. To confirm proper placement, we want to watch for chest rise and fall. If you're working with a BVM and providing rescue breathing for the patient, you'll see that chest rise and fall. You'll see the effectiveness of air moving in and out of the patient's lungs. Leave that OPA in place until the patient begins to gag as their responsiveness returns, or a higher level of medical care uses a more advanced airway device. To remove, we want to grab it by that kind of trumpet flange at the top and just pull it outward and downward, following the curvature of the device, the contour of the tongue. Here's a quick comparison. The OPA goes in the mouth. We can see that in the name, oropharyngeal. The NPA goes in the nose, nasopharyngeal. They're both pretty easy to insert. We want to make sure that both are sized properly. The contraindications are going to be for the OPA if someone has a gag reflex, and for the NPA if someone has skull or facial trauma. Now, additionally, to help a patient breathe, we may use a barrier device. A barrier device just puts a layer between you and the patient as you provide rescue breaths for them. We have a couple barrier devices. The first barrier device is a face shield. The more common one that patrollers carry is a pocket mask, or we'll call it a CPR mask sometimes. But in either case, you're relying on the residual oxygen from your exhalation to support the patient's breathing. Now, a face shield is simply a clear plastic sheet with a mouthpiece that you can seal over the patient's face, breathe through the one-way valve that provides protection to you as the rescuer, and direct your exhaled ventilations into the patient's lungs to support their breathing. You want to make sure that that one-way valve is placed inside the patient's mouth. Pinch the patient's nose and provide a proper seal on the face shield, and you can check effectiveness by seeing chest rise and fall. CPR masks also require a good seal to occur, but they're a little bit more straightforward. They're triangular shaped, so the pointy part of the triangle fits over the bridge of the nose, and then a soft silicone seal allows you to seal to the patient's face and provide effective breaths. In summary, we can maintain the airway by putting a patient in a recovery position, keeping the airway patent with either an OPA or an NPA, and subsequently perhaps breathing for the patient through one of our barrier devices.